So good afternoon, everyone. I respected Vice Chancellor ma'am and other ma'am from the university for giving me an opportunity. Is it audible to everyone?
A little louder.
It's audible.
A little louder, but then I think everyone is able to hear. No issues,
Yeah.
sir.
Okay.
Yes, please go on, sir.
Sure. So critical care emergencies in rural area is a very vast topic. Today, I just wanted to insist on critical care toxicology where we encounter. I wish I always start my slide with the glory of medicine is constantly improving and there is always more to learn. Coming to the toxicological emergencies, previously we used to receive insecticides and pesticides like organophosphorus compound poisoning, organochloride group of poisoning, and plant poisoning like oleander seed poisoning and so on. But nowadays we receive unique type of poisoning like yellow phosphorus, aluminium phosphide, hair dye poisoning, and herbicide poisoning like paraquat. These are very severe poisoning with high mortality rate. I would like to go on with this poison. First, coming to the yellow phosphorus poisoning, which is a rodenticide, which is consumed and the mortality rate is very high. I think in Madras you get from Vilupuram more. And it is available as ratol cake, ratol granules, and ratol paste. So this is the ratol paste, and we compare with the close-up paste. Most of the children take this as close-up paste and they die. You can go to the Google and if you browse, you can see how many people are dying in this yellow phosphorus paste. So coming to the stages, it occurs in 3 stages. The first stage occurs within 24 hours and it is asymptomatic. The patient has got only local gastrointestinal irritation. In the second stage, which occurs between 24 to 72 hours after ingestion, the patient are asymptomatic and may be discharged prematurely. There may be mild elevation of liver enzyme and bilirubin at this state. But during the third stage, which occurs after 72 hours until the resolution of symptoms or death occurs, hepatomegaly and jaundice appear. Acute fulminant hepatic failure occurs, mandating liver transplantation. Bleeding can occur due to coagulopathy and thrombocytopenia. Sometimes, patient may develop acute tubular necrosis and present with acute renal failure. Hemolysis can occur due to destruction of RBCs by phosphorus. The central nervous system, they get mental changes like confusion, psychosis, hallucinations, and coma. And the cardiac toxicity includes hypotension, tachycardia, arrhythmias, toxic myocarditis, and cardiogenic tox. How are we going to manage? We do not have any specific antidote. It is directed towards the removal of the poison and supportive therapy. Gastric lavage we give with potassium permanganate, which converts the phosphorus to relatively harmless toxide. Activated charcoal is used as 1 gram per kg body weight and multi-dose activated charcoal 0.5 gram per kg body weight every 6 hourly. Non-fatty purgatives like magnesium sulfate to eliminate the poison. We get more toxicity to charcoal and nowadays we adopt gastroscopic decontamination where we directly visualize the stomach and give stomach wash so that it is cleared. And coming to the management, we start with N-acetylcysteine even for acetaminophen poisoning and this ratol poisoning and hemodialysis if renal failure develops. Therapeutic plasma exchange in acute renal failure. How are you going to give this N-acetylcysteine? During immediate presentation or late presentation? The dose varies. During immediate presentation, we call it as 20 hours dose. We give a loading dose of 150 milligram per kg IV in 30 minutes and 50 milligram per kg IV in 4 hours, then 100 milligram per kg IV in 16 hours. When presented late more than 10 hours, a loading dose of 150 milligram per kg IV in 1 hour and a maintenance dose of 70 milligram per kg IV in 4 hours for at least 12 doses are given. Injection glutathione, a precursor of acetylcysteine, is given 600 milligram daily for 5 days And induction vitamin K for coagulopathy we give for 5 to 7 days. And finally, they go in for acute liver failure, and it is defined by hepatic encephalopathy and loss of synthetic dysfunction within days to weeks of the first symptoms of liver disease. Hyperacute liver failure occurs between 0 to 7 days. Acute liver failure occurs between 8 to 28 days. Retal paste, 5% yellow phosphorus, produces hyperacute liver failure because the liver failure occurs between 0 to 7 days. And it has got a high mortality rate, and it is due to acute metabolic disturbances, hepatic encephalopathy, and severe coagulopathy. Up to 70% of liver necrosis, liver support system improves the survival because the liver has got an extensive regeneration capacity. Only if more than 90% of liver necrosis occurs, liver transplant is the choice. Following liver transplantation, the survival rate improves. Progressive hepatic synthetic and metabolic dysfunction leads to coagulopathy, jaundice, renal failure, worsening encephalopathy, and metabolic dysfunction. So how are you going to support the liver? We have got two systems. One is therapeutic plasma exchange and other is liver dialysis or MARS. Uses of therapeutic plasma exchange in hepatic failure, it removes the plasma bound as well as heavy molecular weight toxin, including ammonia, endotoxin, indoles, and mercaptans responsible for hepatic coma and hyperkinetic syndrome. It improves the cerebral blood flow, mean arterial pressure, cerebral perfusion pressure, cerebral metabolic rate, and increased hepatic blood flow. It also improvement in laboratory parameters. They show increase in the cholinesterase activity and galactose elimination capacity. It restores hemostasis by providing the coagulation factors, and it removes activated clotting factors, tissue plasminogen activator, fibrin, and fibrin degradation products. In recent series, TPE was shown to decrease the cytokine level, IL-268 and TNF-alpha, which are generally seen as an important for the systemic inflammatory state in these patients. That's what this TPE is also used in COVID-19 cytosol. In some patients, the liver may recover during TPE, and in other patients, failure may persist, necessitating liver transplantation. Aggressive TPE has been used as a bridge to liver transplantation. How are you going to quantify the involvement of the liver? Lack of representation of a liver as a whole, since most features are diffuse, and coagulopathy due to liver biopsy increases the risk of bleeding. So these are all the limitations of liver biopsy. But nowadays we do quantification of the involvement of fat in the liver by MRI, for which we should know the functional liver anatomy. The MRI fat quantification is classified as if below 6 quantification is there, 5% of the cells are affected and it is grade 0 or normal. 16 to 14 fats are affected, 5 to 33% of the cells are affected and it is grade 1 or mild. Is 15 to 20 segments are affected with the fat, 34 to 66% of the cells are affected and it is grade 2 or moderate. And if it is grade severe, more than 20 quantification are there and more than 67% of the cells are affected. So this is for a patient where the fat quantification in each lobe is more than 20. So he is having grade 3 hepatic failure, so that more than 67% of the liver cells are affected. And here we can see the photos of the MRI. This is the normal liver echogenicity. And here you can see the fatty liver where the fat has been deposited. And this is grade 1 fatty liver, that is only less than 5% of the cells are affected. Here you can see in grade 3, more than 67% of the cells are affected. You can compare the normal liver with grade 3 liver. So as already told, if less than 70% the liver cells are affected, the liver may regenerate during TPE or MARS. Failure may persist, necessitating the liver transplantation. The supportive care here includes ICU admission, airway protection, hemodynamic stabilization, anti-encephalopathy measures, and antibiotic. How do we do this therapeutic plasma exchange? The access is by central or peripheral vein with an anticoagulant of citrate. 1 to 2 plasma volume is exchanged with fresh frozen plasma with 5% albumin. Continuous vital parameters were monitored. Pre-procedure calcium levels are checked and intravenous calcium chloride given. The replacement fluid for the plasma may be either fresh frozen plasma or 5% albumin. Most studies in TPE for sepsis use fresh frozen plasma because it replaces the plasma clotting factors, no post-pheresis coagulopathy, no immunoglobulin deficiencies. Whereas in 5% albumin, immunoglobulins are lost with plasmapheresis when albumin used as a replacement fluid, and immunoglobulins should be checked in between and it has to be replaced. When do we do this TPE? When the INR is more than 3 and when the liver enzymes are elevated more than 1000 and when the patient has got hepatic encephalopathy. How do we do? 5 cycles of TPE on consecutive days with 1 plasma volume exchange during each cycle. As already told, the replacement of fluid, mostly FFP or sometimes albumin we use. Membrane filtration technology applied in critical care medicine setting is not very effective. Here you can see the membrane filtration technology. Here instead of hemodialysis cartridge, you just connect a plasma filtered cartridge. Even it is more effective where the centrifuge technique is not available. The next is the centrifugation technique, which we have here and in the COVID centers and in the blood bank, where you can remove 1 to 2 volumes of plasma with excellent results. The next liver supporting system is MARS. It is molecular adsorbent recirculating system. It uses albumin dialysis using the molecular adsorbent recirculating system. We call it as MARS. In this device, the blood is dialyzed across an albumin infiltrated membrane against 20% albumin. Charcoal and anion exchange resin column in the subtube clean and regenerate the albumin dialysate. In this system, we find significant improvement in hyperbilirubinemia, coagulopathy, and encephalopathy. And this is a case of MAS. This patient was admitted in Chidambaram Medical College and he became bad and he was sent to Stanley Medical College. From there, his bilirubin was more than 24 and he was sent back to our hospital. And totally, we have done 2 MARS for this patient and he survived. And what is the significance of the liver function test? The magnitude of the elevation of liver enzyme and rate of decline do not affect the prognosis. Prognosis depends on serum bilirubin concentration and INR. Bilirubin level continue to increase due to intrahepatic cholestasis and INR remains prolonged despite declining ALT levels. And blood lactate is a very important prognostic factor for the patient's recovery. And the take-home message in this poison is features of hepatotoxicity with inorganic phosphorus often develop 72 hours after ingestion. During this time, the patient has got only mild gastrointestinal symptoms and no other symptoms. Unless looked specifically, clinical evidence of icterus or an abnormality in the LFT can be missed. And elevation of prothrombin time can be wrongly attributed to a warfarin containing rodenticide. LFT and PT should be mandatory in all cases, and all rodenticide poisoning patients should be reviewed at least once with LFT in a week's time. Totally, we have treated 25 patients, 22 on plasmapheresis and 3 on molecular adsorbent recirculating system. We have lost 3 patients on plasmapheresis and 1 on MARS. Application of this treatment modalities can also be used in acetaminophen poisoning and they used in abroad, and mushroom poisoning like Amanita phalloides, herbal poisoning, and carbon tetrachloride poisoning. The next important poison is aluminum phosphide poisoning and saving lives with ECMO in rural area, making the impossible possible with cardiac support. Here again, we call this tablet as Selfos, the pellets with no specific antidote, and treatment is directed towards a removal of the poison and supportive therapy. Normally, gastric lavage is given with coconut oil or liquid paraffin because it gets dispersed in water, and we give potassium permanganate, charcoal, and multi-dose activated charcoal. But most of the patients go in for severe refractory cardiogenic shock, for which initiation of vasopressors and inotropes at maximal doses through central venous cannula and amiodarone magnesium sulfate for ventricular tachycardia and glucose insulin potassium for cardiogenic shock is instituted. Once if the EF is less than 35%, we go in for IABP, and if the EF falls below 25%, we go in for VA ECMO, which is the only choice of treatment. And we all know about ECMO now because of the COVID days. It is a temporary support of the heart and lung function by partial cardiopulmonary bypass. We have got VA ECMO, which is majority used for cardiac problem. VV ECMO, blood is pumped from venous side, then pumped back into the venous side in respiratory failure, and ARDS. Mostly for COVID-19, we use VV ECMO. And this ECMO is used for acute circulatory shock, not responding to conventional supportive therapy. During severe heart failure, initially we give volume therapy, then vasoactive medication, and intra-aortic balloon counterpulsation. Finally, if it fails, we go in for ECMO. And this ECMO is extensively used nowadays in toxicological emergencies causing refractory cardiac dysfunction. The most common poison here is aluminum phosphide poisoning, and abroad, and we have also got a couple of cases of calcium channel blocker poisoning with excellent result on ECMO and MARS. How are we going to initiate this ECMO? Refractory ventricular fibrillation with multiple defibrillatory shock are ineffective, and if the ejection fraction in echocardiography is less than 25%, we have to initiate the ECMO. Here you can feel the normal contraction of the heart, and this is a ventricular fibrillation. Immediately after defibrillation and amiodarone, the patient becomes normal. And this is a patient on ECMO. Along with ECMO, we also use CRRT and ventilators, CRRT to maintain the volume. And here you can see the ECMO machine in short, and this is the oxygenator, and this is the rotatory pump. This is the hypo and hyperthermia to maintain the temperature. And this is the patient on arrival with tachycardic, BP 60 by query, pH severe acidosis, that is lactic acidosis, multiple defibrillation, and extensive vasoactive drugs like noradrenaline, followed by vasopressin, adrenaline, and dopamine, and mean arterial pressure was not recordable. After ECMO, after 72 hours, he has become normal with a normal heart rate and normal BP and normal lactate clearance. He was on support with noradrenaline alone with the MAP of 80, and we tried to maintain the MAP for more than 60 millimeters of mercury. But just removing the ECMO is not enough. Even in COVID, removing the ECMO is not enough. They may have to go in for lung transplantation. Similarly, patients have multitude of problems during post-ECMO period. One is acute limb ischemia, because in VA ECMO, we take the peripheral femoral artery as the access cannula. So the patient has to be given perfused below the femoral artery, or they go in for acute ischemia, gangrene, and amputation of the limb. We have already amputated 2% in our 14 survived patients. And they go in for acute kidney injury, acute liver failure, and septicemia. To conclude, these cases initially were received with hypotension and severe left ventricular dysfunction. They rapidly deteriorate and land up in severe cardiogenic shock, ventricular arrhythmia, and refractory lactic acidosis. Initially, they are treated with antiarrhythmic agent and multi-defibrillation, then IABP followed by VA ECMO. Following decannulation of the ECMO, stopping the ECMO after recovery, owing to ischemic hepatitis and nephritis, they go in for hepatic failure and acute kidney injury. and they are managed with therapeutic plasma exchange along with CRRT or slow SLED and routine hemodialysis. What are all the challenges in ECMO in rural area? All super specialties. Specialists are in cosmopolitans and metropolitans. Only big corporate setups have ECMO. And cases like aluminum phosphide poisoning will not survive till they reach those kind of setup. But still our book teaches majority of population are in the rural area. As ECMO is still in emerging and not many are exposed to ECMO, very few consultants are aware about pros and cons of ECMO therapy. Till now, we have performed 14 cases of peripheral VA ECMO for aluminum phosphide poisoning with 4 deaths. Thank you. Next, we go to the hair dye poisoning. Super Vasmol. This is an hair dye which is freely consumed by the Sri Lankan refugees who have been given shelter in Erode and Coimbatore district and also in Andhra. Ingestion of 100 ml of dye leads to laryngeal edema, acute renal failure, and rhabdomyolysis. It is a widely used hair dye in India and it has a potent nephrotoxic cocktail containing pyrophenylene diamine, propylene glycol, and resorcinol. The characteristic features are severe angioneurotic edema, rhabdomyolysis, intravascular hemolysis with hemoglobinuria, and acute renal failure. The patient initially they get admitted and they are normal, but when we explain them within 2 to 2 hours they will go in for airway problem. They never accept, and once if they get it immediately, you can see this patient immediately they accept.
என்ன பண்ணுது என்ன பண்ணுது உங்களுக்கு இப்போ வளர்க்குது பேச முடியல எனக்கு வந்து பார்க்க முடியல தூட முடிய மாட்டேங்குது சார்.
So immediately this patient we were not able to do, and immediately within few seconds, because he went in for angioneurotic edema. So we went in for percutaneous tracheostomy and we saved this patient. So always these kind of patient, when they take hair dye, you have to be very careful and you should be prepared to maintain the airway. Further, this PPD promotes calcium release and leakage of calcium ion from the smooth endoplasmic reticulum, followed by continuous contraction and irreversible change in the muscle structure. So this rhabdomyolysis is a common cause of renal failure, and this can be treated with forced alkaline diuresis so that you can prevent the development of acute renal failure. To conclude, this hair dye injection is a common cause of attempted suicide in rural area, which consists a number of nephrotoxic chemicals which may lead to respiratory, musculoskeletal, and renal manifestation. At early recognition and prompt treatment can lead to reduction in the incidence of rhabdomyolysis and renal failure. And next comes a challenging, what we call it as weedicide or herbicide, management of paraquat. Some people say paraqua poisoning, which is a herbicide available in granular or water soluble form. In India, it is available only as water soluble form, 24% solution. As a water soluble form, it is rapidly absorbed and it gets accumulated in the lungs and kidney after absorption. More than 90% of the absorbed dose is excreted by the kidney as paraquat compound. Within 12 to 24 hours, highest concentrations are found in the kidney and lungs. It also accumulates in the muscle tissue, which acts as a reservoir, explaining prolonged detection of plasma or urine paraquat weeks or months following injection. Most of these patients go in for respiratory pulmonary fibrosis and they are candidate of lung transplant. When we ask the people about lung transplant, the physician used to say, even after the lung transplant, because of the it is in the muscle tissue as a reservoir, it is slowly released and the lung transplant gets rejected and they are not a ideal candidate for lung transplant. So these are all the paraquat how we get. Once if you dissolve in water, it goes in for this bluish green color. Normally less than 20 ml, it results in moderate gastrointestinal symptom. 20 to 40 ml results in death within 5 days, and more than 40 ml usually results in more than 1 to 5 days. I know Raghunandan doctor will be knowing about this extensively. And the degree of systemic toxicity is governed by paraquat ingestion, and it occurs through subcutaneous, intraperitoneal, intravenous injection, and in the oral route. It affects almost all the system. In the gastrointestinal system, local action, nausea, vomiting, and diarrhea. But moderately or severe poison patient may develop burning sensation, soreness, pain in the mouth, throat, and retrosternal area. The abdominal pain, vomiting, and diarrhea often soon after ingestion. Here you can see ulcers in the upper GI endoscopy, corrosive effect of paraquat poisoning in the mouth, and in the esophagus, it produces perforation with mediastinitis, surgical emphysema, pneumothorax, pleural effusion, which is associated with pleuritis. Frequent complications are jaundice, hepatomegaly, and central abdominal pain, which may be secondary to pancreatitis. Here, a patient with jaundice. And normally, we take CT lung in paraquat, and you can get all the complications like pneumomediastinum, pneumothorax, interstitial edema, pulmonary fibrosis, and consolidation. Such a severe poisoning, which has got a very high mortality rate. Coming to the kidney, it produces acute tubular necrosis within 24 hours, which may be oliguric or non-oliguric, and proximal tubular dysfunction may develop in 2 to 6 days, which progresses to anuria. Renal dysfunction results in proteinuria, microscopic hematuria, glycosuria, aminoaciduria, phosphaturia, and excessive leakage of sodium. Coming to the lung, when consumed more, it produces protective blood-stained cough, and dyspnea occurs early due to ARDS, consumption of substantial amount, late due to pulmonary fibrosis, and rarely due to pneumothorax, that is mediastinitis, pleural effusion, and iatrogenic pulmonary edema. They go in for declining PO2 with resultant central cyanosis due to declining gas transfer factor and vital capacity. And regarding the X-ray, already I have shown you about the CT, and survivors may have restrictive type of pulmonary function. Here, a case of pulmonary edema who has consumed enormous amount of paraquat poisoning. And we did even a biopsy after the death of the patient, where it shows thickening of the alveolar septa due to abundant fibrosis and areas of interstitial hemorrhage with thickened septa. And small pulmonary arteries are within the thickened alveoli, and muscular hypertrophy of the tunica media along with intimal thickening. So finally, if the patient said they have got, even after the death is due to extensive pulmonary involvement, and even if they survive, they go in for severe pulmonary fibrosis. And late signs and symptoms are convulsions, which may be due to cerebral edema precipitated by fluid overload, and coma is a common terminal event. And the terminal event is due to cardiovascular causes like multiple dysarrhythmias. Finally, sinus bradycardia, hypotension, cardiac arrest, which may supervene. Chest X-ray may show massive cardiomegaly, and postmortem examination reveals toxic myocarditis. Coming to the lab detection, normally bedside urine dithionite test is used. Nowadays, for all the cases, we do urine dithionite test because we have to know whether they have consumed this paraquat or they have consumed organoporous and so on. Additional modalities like gas chromatography and radioimmunoassay. This urine dithionite test, how do we do? It is a qualitative urine test and detects concentration of 1 milligram per ml. Normally, 10 ml of urine is added to 2 ml of 1% solution of sodium dithionite. In 1N sodium hydroxide, a blue color indicates the presence of paraquat. Here you can see a normal patient, a patient with paraquat, and when you do hemodialysis or hemoperfusion, we repeat every half an hour, gradually the color goes off. But again, the next day it comes because again the paraquat poison, which comes from the muscle and the kidney, they get dissolved in the plasma with high concentration. Gas chromatography detects a level up to 1 to 2 micrograms per ml and radio immunoassay up to 0.1 microgram per ml. How are we going to manage? Appropriate supportive care, removing paraquat from gastrointestinal tract, increasing its excretion from the blood, and preventing cellular damage with selected agents. How do we prevent gastrointestinal absorption? Fuller said what they call it as this muntane milk is something what they use for facial, the girls, ladies use for facials, is administered as 30% suspension along with magnesium sulfate to produce a catharsis. Activated charcoal may be administered 1 gram per kg up to 50 gram. Gastrointestinal decontamination should be performed as quickly as possible, owing to the rapid absorption of paraquat after oral exposure. This Fuller's earth and activated charcoal absorbs all the poison in the stomach. Extracorporeal technique, either by chemodialysis or chemoperfusion, is recommended. It has to be done within 12 hours. Chemoperfusion is better than chemodialysis. Hemodialysis should be done for a period of 4 to 6 hours, or when you use a hemoperfusion cartridge, according to the concentration or the absorption of the cartridge, you can use it between 1 to 2 hours. Daily treatment should be continued. Here you can see a patient on hemoperfusion cartridge. And we have to go in modulation of inflammatory response because to prevent pulmonary fibrosis. The pulse therapy we use cyclophosphamide, methylprednisolone, and dexamethasone. Cyclophosphamide 15 milligram per kg per day for 2 days. Methylprednisolone 1 gram IV OD for 3 days. And dexamethasone 8 milligram IV 6 hourly for 14 days. Cyclophosphamide induced neutropenia can be treated with filgrastim 0.9 milligram per 30 mg. Here is a case who fortunately survived. Most of the case die because in India they do not consume less than 40 ml. They consume more than 1 liter. So he has survived, and you can see alopecia secondary to cyclophosphamide, and he became normal after 1 month. And anti-fibrotic agents nowadays we use, usually we try pirfenidone 200 milligram tablet thrice a day for 5 days, and twice a day for 5 days, and once a day for 5 days. But nowadays in COVID-induced pulmonary fibrosis, they recommend, because this has been used for idiopathic pulmonary fibrosis, this pirfenidone 2400 milligram administered orally or nasogastric at 800 milligram TID for 4 weeks. This has been recommended for COVID-induced pulmonary fibrosis. We are yet to venture, and next paraquat poisoning we want to treat because most of the patients die of pulmonary fibrosis. And to prevent oxidation, we use vitamin C, vitamin E, and already told this N-acetylcysteine, we call it as universal antidote. Like rat oil poisoning, we continue with this 20-hour dose. Supportive measures, maintaining intravascular volume, monitoring of vital signs, monitoring arterial blood gases, and treatment of complications. To conclude, despite aggressive critical care management, paraquat poisoning carries a very high mortality rate. And this is an extensive topic, so I want to conclude with the venomous snakebite critical care management. Indian venomous snake are cobra, krait, viper, and sawsquirrel viper. I am a student from Stanley Medical College. I have not even seen a single case of snakebite during my career and even during my postgraduate career. These are called big four snakes because they are responsible for the maximum death in India. Now they have found this hump-nosed pit viper, which also causes, and it is in the Western Ghat in Kerala, Maharashtra, and Western Ghats of Tamil Nadu. So nowadays, these big 5 snakes causes maximum death in India. The neurological signs include, mostly it affects the cranial nerves, producing diplopia, dysphagia, bulbar palsy, dyspnea, limb weakness, and ventilatory failure. they produce airway compromise, which may be secondary to altered mental status, aspiration, obstruction, secretion, and laryngospasm. Here I would like to show most of the victims of snake bite are farmers, military people, and snake charmer. You can see a snake charmer who is showing a snake show in a village. Now he is keeping the cobra in his mouth. He was bitten by this cobra. Immediately he takes the cobra and keeps in a bag side by where he has got so many snakes, because he knows once if he falls down, it will offend all the public. See, now you can see the snake has bitten his tongue. He is not even telling his assistant. He has kept inside the bag and closes the bag, which contains plenty of snake. Immediately, he was brought back to a primary health center and he was referred to our hospital. He was in a semi-conscious state and immediately he was intubated. This is where he was bitten. Here, what I would like to insist for the postgraduates are any injury in the face, any stings or bite or burns, immediately you try to protect the airway immediately, because once if the face and the neck swells, it is very difficult to maintain an airway. So immediately on the second day, you can see how this has been swollen. So it may be very difficult to intubate the patient. And we did percutaneous prophylactic tracheostomy, because if there is inadvertent removal of the endotracheal tube, it is very difficult to re-intubate. On the fourth day, there was necrosis in the bitten area and ulcers surrounding the tissue. On the seventh day, the soft tissue swelling completely reduced. There was demarcation of the necrosed area, which was appreciated well, and he was weaned off from the ventilator and he was referred to a plastic surgeon. And you get fasciculations like this, and it is very difficult to maintain, and it is one of the cause of the airway compromise. And the important neurotoxicity in a snake bite is ptosis, which is the first outward manifestation of neurotoxicity. Once if the patient goes in for ptosis, immediately the emergency department should be ready, because at any time he will go in for ventilatory failure and ventilatory support is needed. And he was bitten by this spectacled cobra. Coming to this cobra, cobra is one of the elapid snake. The offending toxin produces non-depolarizing types of neuromuscular block. Ptosis is the first outward manifestation. So it is just like non-depolarizing muscle relaxant given during anesthesia, like pancuronium, atracurium, and so on. So we have to reverse with 3 milligram of neostigmine and 1.5 milligram of atropine, which should be given slowly intravenously. And we repeat this dose 1/3 every second hourly, and the dose is gradually tapered. Premature discontinuation will lead to relapse. This should be followed by simultaneous administration of ASV. Atropine has a tendency for delirium, so we may go in for neostigmine and glycopyrrolate. Neostigmine atropine combination, if it does not reverse the neuromuscular block, and if the paralysis of the respiratory muscle persists, then he has to go in for ventilatory support. Indications of ventilatory support, we confirmed with arterial blood gas analysis. If the PaO2 is less than 60 millimeters of mercury with the FiO2 of 60%, and if the PCO2 is more than 45 millimeters of mercury with the pH less than 7.35, and absence of cough and gag reflex. Usually, ventilatory support is required for around 10 days for elapid snake bite. We all know the snake venom is circulated in the plasma. When we do 2 cycles of plasmapheresis, the patient can be weaned by the ventilator early. Here you can see a lady who was bitten by a cobra snake, and she was connected to the ventilator, and we did plasmapheresis immediately for her. Normally, she has to be ventilated for a minimum of 10 days. So here we have been doing plasmapheresis, and the plasma is being removed because the plasma contains the snake venom. Immediately after plasmapheresis, she is able to open her eyes and tongue. And you can see her right upper limb, which is swollen, was bitten by the snake. Next elapid is crate. This crate has a nocturnal habit like us when as we are going to a nightclub. And these crate fangs are so soft, it does not produce pain, no swelling, no mark at the site of bite. So in a rural area, once if you receive a patient who are areflexic and has got fixed dilated pupil, you don't diagnose as brain death. The differential diagnosis should be the crate envenomation. See, you can see the normal long fangs of a other poisonous snake and a small short spongy fang of a crate. Further, this produces axonal damage, and the paralysis is predominantly presynaptic, not postsynaptic like cobra. So this neostigmine atropine does not have any value for crate envenomation, and the recovery depends on the axonal repair. And this is a crate snake. So as already told you, presynaptic neurotoxin, which is predominant, it targets the terminal axon of the neuromuscular junction, extensive damage to the axon structure, complete dissuppression of the transmitter synaptic vesicle, cessation of the transmitter lead, and progressive flaccid paralysis. Once if the paralysis is complete, the recovery rate is dependent only on the axonal repair and not by anti-snake venom. So we have to wait till the axonal repair is complete. And here I will show a movie. This small girl was received with a crate bite. On the first day, she was areflexic with fixed dilated pupil. On the second day, slowly she is able to frown and she is able to open her eyes. Then on subsequent days, slowly she is opening her eyes. And on day 4, she has completely opened her eyes and she is able to protrude her tongue out. And on the 5th or 6th day, she is able to move her limbs slowly. And this is on the 7th day, she is on ISTPs and she is able to flex her limb. So on the 8th day, she is almost completely conscious. On day 10, she is almost normal. So here the differential diagnosis, what we want to insist is, in a rural area, if you receive a patient with no evidence of snake bite, who are areflexic with fixed dilated pupil with shallow respiration, the differential diagnosis is crate bite, immediately intubate them, and it takes 10 to 12 days for them to recover. The hematological signs and symptoms, coagulopathy occurs in Russell's viper in South Asian countries. This coagulopathy, we call it as venom-induced consumption coagulopathy. Bleeding from the gum is the first outward manifestation. Suppose if there is a tinge of bleeding from the gum, immediately we should suspect coagulopathy and we should be very active in resuscitating them. But anytime they may go in for bleeding and the complication of coagulopathy. Here you can see the persistent site of bleeding from the site, hematuria, gingival bleeding, epistaxis and hemoptysis, ecchymosis, subconjunctival hemorrhages. Retroperitoneal and intraperitoneal hemorrhage causes abdominal distension, tenderness, and peritonism with signs of hemorrhagic shock. Here also the bedside test, what we call it as 20 WBCT, 20-minute whole blood clotting test. Just take 5 ml of blood in a test tube, keep it. Leave undisturbed for 20 minutes in ambient temperature. Tip the vessel once. If the blood does not clot, it is hypofibrinonemia, which is a result of DIC, which occurs in viper bite. So within 30 minutes, you will know the patient has been bitten by the Russell's viper. அந்த காலத்திலே சொல்லுவாங்க விதி முடிஞ்சாதான் விரியன் கிடைக்கும். With this Russell's viper bite, all the systems, critical care system, you can learn. And this is a chart which normally we follow for WBCT, coagulation profile, ASV, blood and blood products. Criteria for severe coagulopathy here is INR more than 3, APT 50 seconds, platelet less than 50,000, and fibrinogen 75 milligrams per deciliter. If the platelet is less than 50,000, 2 units of fresh frozen plasma or platelet concentrate is transfused every day till platelet count starts improving. Current trend is to start anti-snake venom 60 ml for a period of 6 hours, which is followed by 20 ml 6 hourly, with 2 units of fresh blood at 12th hour interval, and the coagulopathy gets corrected within 24 to 36 hours in 95% of the patient. It is assessed by repeating the 20 WBCT every 6 hours. If the patient is in AKI, acute kidney injury, it has to be given during dialysis to avoid fluid overload. The advantage of transfusing whole blood takes care of the coagulopathy. Also provides adequate hemoglobin for oxygen transport. Because of the unavailability of whole fresh blood, the components are used. Heparin and antifibrinolytic agents are ineffective in snakebite. Here in ultrasound, you can see the coagulopathy, you can see the pleural effusion, but mostly it is a hemothorax. And you can see the perinephric fluid, free fluid in the abdomen, all are blood. And you can see the collapsed lung in the ultrasonography. So once if we try to aspirate, it is only frank blood. And you can see frank blood compete one. The lesson what we learned, once if the patient is in coagulopathy in snake bite, please do not attempt any invasive procedure, including catheterization. We have to be very careful because you may lose the patient with hemorrhage. And here we see the echocardiogram where you can see the pericardial effusion and the left ventricular function. And you can see subarachnoid hemorrhage, intracerebral hemorrhage, and this is cavernous sinus thrombosis in the case of snake bite, right MCA infarct in both in CT and MRI. And this is the diagnosis of brain death. Normally, nowadays, in any case in ICU, we do a MRI to see the architecture of the circle of Willis. If the architecture of the circle of Willis is lost, the patient is brain dead. If it is preserved, then he is not dead. Plasmapheresis in envenomation is used as adjuvant for snake envenomation, decreases venom-induced toxicity, and it relieves the complication and reduces the hospital stay. And membrane filtration technology we use in critical care setting. Already I told about plasmapheresis in ratol poisoning, and we use either albumin or fresh frozen plasma. Here they prefer albumin because the risk of hypersensitivity reaction and transmission of blood-borne infection is less. Normally, we use unfractioned heparin as anticoagulant. We use double the dose in plasmapheresis because substantial amount of infused heparin is removed along with the plasma. Normally, we use 2 cycles of plasmapheresis, first after 6 hours following the bite, 2 on the second day, with the hypothesis that the injected snake venom is primarily absorbed by the lymphatics and later drained to the blood. The delay of 6 hours is for allowing time for plasmapheresis procedure to access the venom in the blood. The advantages, most of the time, anti-snake venom dose is reduced, rapid swelling and avoids compartmental syndrome, correction of DIC, and reduces the frequency of dialysis in snakebite-induced AKI, correction of snakebite-induced sepsis and septic shock, reduces the patient days on ventilatory support, and overall significantly reduces morbidity and the cost of the hospital stay. Here a patient on centrifugal technique of plasmapheresis. Acute kidney injury in snake bite is due to viper. It is either due to the direct effect of the toxin or because of hypotension. Earliest signs are oliguria and hematuria. And we do POCUS, that is point of care ultrasound in snake bite. Because within 2 to 4 hours after necrotoxic snake bite, the abdomen scan reveals poor corticomedullary differentiation, indicating acute tubular necrosis. The urea and creatinine generally rises only after 12 to 24 hours. But even before that, we can see the perinephric fluid collection, which denotes early AKI. Similarly, when we do renal Doppler, the resistance index is more than 0.75, it denotes AKI, which is revealed within 6 hours in nephrotoxic snake bite. So before the urea and creatinine raises, you can see the changes in the renal damage by ultrasonography. And we do urine routine, which shows granular cast and deranged RFT. Here you can see a normal kidney with normal corticomedullary differentiation. Here the corticomedullary differentiation is lost. Here you can see the perinephric edema on both the kidneys. And this is the renal Doppler where this is high resistance. Here you can see both the systolic and diastolic wave. You can see only the systolic wave. The diastolic wave is 0. And nowadays, instead of measuring central venous pressure, we all know we do regularly IVC estimation every 1 to 2 hours. If the IVC size is less than 1.6 centimeter, it shows hypovolemia. If it is more than 2 centimeters, it shows hyperolemia. So to manage, early prophylactic dialysis is indicated when there are changes in the kidney, even if the urea and creatinine were found to be normal for ultimate early outcome. And if oliguria sets in, initially we go in for furosemide stress test with administration of 200 milligram of furosemide at 4 ml per hour, 40 milligram per hour intravenously, and the urine output is monitored. If there is no adequate urine output, one more 200 milligram dose is repeated. Usually the benefit occurs after 6 hours. This furosemide stress test converts the oliguric phase to diuretic phase. Similarly, to minimize the risk of renal damage from myoglobinuria and hemoglobinuria, we have to correct hypovolemia. So we see the contraction of the heart to see the contractility, and also see the IBC to see the preload, and accordingly we treat. Severe acidosis treated with bicarbonate. Ongoing rhabdomyolysis, sepsis, hemolysis, and hypercatabolism may aggravate acidosis and hyperkalemia. We have to be very careful. If renal shutdown occurs, hemodialysis is contemplated. And the femoral catheter must be the vascular access for hemodialysis in a patient who is bleeding, because subclavian and internal jugular vein as vascular access may prove detrimental like this. So once if the patient is in coagulopathy, you have to do renal dialysis. Usually the first choice should be femoral dialysis, femoral catheter. And some patient will go in for renal cortical necrosis who suffer oliguria for more than 4 weeks and go in for diffuse bilateral renal cortical necrosis. It is confirmed by renal biopsy and contrast enhanced CT scan of the kidney. They require regular dialysis support and eventual renal transplantation. The hypotension and shock, hypovolemia from loss of circulating volume in swollen limb or internal and external hemorrhage, and it may be due to venom-induced vasodilatation, direct myocardial effect of the venom, cardiotoxicity with or without arrhythmias, anaphylaxis induced by antisnake venom, respiratory failure, acute pituitary adrenal failure, and septicemia. Hypovolemia is treated with IV fluid controlled by CVP, nowadays by IVC monitoring, and excess volume replacement may cause pulmonary edema. Acute pituitary adrenal insufficiency occurs in Russell's viper bite and contributes to shock. Hydrocortisone is effective in these cases. Septic shock is a challenging in the management of snake bite, where they go in for sepsis septic shock. It is very common in Russell's viper envenomation, and it is challenging to treat. Here we can see a patient with severe septic shock and with the less contraction with intra-aortic balloon pump. And gradually we see the improvement of the contraction of the heart on the first day and the contraction of the heart on the final day. And we can do wonders with intra-aortic balloon pump if the ejection fraction is less than 30%. Another challenging thing is capillary leak syndrome. One of the etiology is snake bite, and inflammatory mediators play a key role in this CLS. The diagnostic features are hemoconcentration, hypotension, generalized edema, and hypoalbuminemia without albuminuria. How are you going to treat? In brief, initial phase of CLS requires fluid resuscitation. So if there is volume overload, which is a second phase of CLS, it may require a diuretic or ultrafiltration, which can be done by dialysis machine. In some specific condition, colloid has been found to be superior to crystalloids. In nutshell, early diagnosis, good supportive care, monitoring of the fluid and electrolyte status, vasopressor therapy, antibiotic, and ventilatory support are essential in the management of CLS. Here you can see the CLS in the third space. Treatment of the bitten area, which may be painful and swollen. So it should be elevated. Broad spectrum antibiotic is used to combat the infection. Metronidazole is used for anaerobic infection. Necrotic area requires sloughing of the skin and skin grafting. This is the necrotic area. Next one is the compartmental syndrome. So this compartmental syndrome can be avoided by proper plasmapheresis, and irreversible muscle damage can be prevented by early administration of ASV. Local ASV can cause severe pain and increases the intracompartmental syndrome pressure. So before, during fasciotomy, normally we never do, but if it is absolutely indicated and if the pressure is more than 40 millimeters of mercury, hemostatic abnormalities must be corrected. There should be clinical evidence of compartmental syndrome. And if the intracompartmental pressure is more than 40 millimeters of mercury, and it can be easily measured by introducing the cannula connected to the pressure transducer or manometer. So this is fasciotomy. And tetanus prophylaxis, because tetanus organism may flourish in the fangs of the poisonous snake and in the devitalized tissue. Injecting tetanus toxin and human tetanoglobulin is effective. Analgesic for severe pain, we go in for narcotic analgesics, but used in caution in respiratory failure. In renal failure, nephrotoxic drugs are avoided. Nowadays, we use this patch, fentanyl patch and norcuron patch. Dextropropoxone or paracetamol can be used in nephrotoxicity. And another challenging is necrotizing fasciitis in snake bite. Fasciitis involves a subcutaneous tissue and deep fascia. The clinical presentation may be masked as changes in overlying skin may only be observed later in the disease process. So here a patient with necrotizing fasciitis who went in for wound debridement and after 2 hours has become completely normal. Within 6 hours, the necrotizing fasciitis becomes so bad and he goes so bad. So here the confirmation of diagnosis is just an X-ray chest of the affected part or MRI, where you can see the air shadows in the necrotizing soft tissue infection. You can see the air shadows here. This is a lethal disorder, should undergo immediate surgical debridement. You should do culture sensitivity and broad spectrum antibiotics that cover gram-positive cocci, gram-negative bacilli, and anaerobic should be used. Anti-snake venom in pregnancy. In these 30 years, we have received almost 5 to 6 cases. Now we have got a case. Same dose of anti-snake venom should be given. We have to monitor signs of fetal distress, fetal heart rate, vaginal bleeding, abdominal pain, and ultrasound of fetal heart. Ultrasound has done wonders nowadays. And this lady has been the bitten side is the left leg and the culprit is a Russell's viper. Rehabilitation is a neglected part. Restoration of the normal function. Conventional physiotherapy for severe local envenomation. And the take-home message here is anti-snake venom is indicated in venomous snake bite. Remember, it has got its own side effect. Neosegment and glycopyrrolate are atropine to neutralize the non-depolarizing muscle relaxant in cobra bite. Great envenomation is mostly presynaptic, and if axonal damage occurs, anti-snake venom is of no use. Mechanical ventilation in ventilatory failure in elapid snake bite. RRT in viper envenomation. Fresh whole blood or blood products for coagulopathy. Identifying early sepsis and early goal-directed therapy in sepsis, and plasmapheresis to reduce the complication. And to conclude, the indispensable successful teams. Today, each of us will give our best. Respect will permeate from all of us. unstoppable patient will guide us. Steadfast unity will hold up and help us through the challenges. Together we can and will keep winning. Thank you. எங்க வருது எப்படியா?
Very much, sir, for the wonderful presentation.
Thank you,
The
sir.
take-home message was succinct and excellent, sir. Thank you very much again. It looked like attending my classes again as a postgraduate student. Wonderful, sir. Thank you.
Thank you, sir.
And now request Dr. Shanti Mallar Madam to give her inputs. Madam? Shanti Mallar Madam? Please unmute yourself, Madam.
Yes.
Shanti Mallar Madam?
So good evening. Am I audible?
Good evening, Madam.
Yes, am I audible? Hello.
Audible now, Madam.
Hello.
Yes, madam. Is it audible?
Sir, not able to hear.
It is audible, sir. Ganapathy, sir, you please close your share, sir. Share screen can be closed now.
The shared screen can be
Yes, sir.
closed. Slide share screen can be closed,
Yes,
please.
madam.
Just have to pick up that stop share, sir.
Yeah.
Please go to WebEx and then close, sir.
Okay. Okay, ma'am.
Yes, sir. Thank you very much, sir. Yes, madam.
Sure.
Shanti Mallar Madam, please start, madam.
Sir, good evening. Sir, Ganapathy sir, thank you very much for
Yes,
your
ma'am.
extraordinary studies. For almost 4 decades, you have done a good job for the societal emergency health needs. It's not so easy in a small rural setup until 1983, so starting in 1983. So such a wonderful job you have done, and
Thank you, madam.
very happy that I am also part of Stanley. I did my diploma in anesthesia in Stanley also, and as you said, it's a poison. Actually, almost or poisons and medicines are oftentimes the same substance given with the different intents. Even small quantity can damage and can lead to death, actually. It's like a chemical monkey wrench. So you have covered almost all the toxicology topics like organophosphorus and paraquat, air dye, and aluminum phosphide. Most common nowadays, as you said, it's most commonly misused aluminum phosphide.
Yes.
And regarding this venomous snake venom, it's only mostly in the rural setup because you are not seen in Stanley. Even during my study, 2-year study diploma, I have not seen a snake bite in Stanley
Yes.
study. This main thing is, how do you, for example, create awareness on that? Actually, information, education should create awareness among the public, especially the rural setup. How to prevent the aspect, then how we are going to bring as early as possible to the healthcare system, maybe in private setup or government setup. Your ideas, sir,
Yes.
please.
Yes. Actually, initially, some 10 years back, we used to have a separate ambulance, and we used to go to all the villages and tell the Panchayat fellows,
Yes,
and
sir.
we show the movies there. And before the movies, for the crowd, first we will put this Senthil Kaudamani and Rajinikanth movies. Then you get the crowd, and we show all the movies to them. And also in the local channels, is it audible, sir? In the local channels,
Yes.
we used to send, we used to spread this news. But
Yes, sir.
nowadays we have got this WhatsApp, madam, which
Yes,
is
sir.
very effective. Very effective. WhatsApp is very effective, and we have got so many classes in WhatsApp. And we once if the patient attender come, we show all the things in the WhatsApp outside in our clinic, and also we share it in our website. And also we used to send in WhatsApp with the patient attenders. So it is very easily reachable. And of course it is, I started from 1986, almost 36 years. And now my name is very familiar. They say Ganapathy Hospital, and from 4 districts, wherever you have got snake bites and poison, they say Karangalpalayam, Ganapathy Hospital, Pambadi Hospital, they come. Even now, see, while talking, I have received 2 cases, which I have not seen. My assistant would have seen. So like that, it spreads by mouth. And also the results, madam. If you show results, automatically it come. And we were in Stanley, I was trained, and Dr. Professor T. Srinivasan, also Dr. Ragavalu. We all work 18 hours a day in critical care unit. And it is a patient. Even now I work 16 to 18 hours a day. If you put a patient on aluminum phosphide poisoning, we never sleep for 2 to 3 days. Unless the consultant is there, you lose the patient in aluminum phosphide poisoning.
Yes,
On
sir.
It's just a dedication and commitment, madam. This is
Yes,
how
sir.
we spread throughout the villages.
Yes, sir. So thank you very much for that. But for example, in villages, it's a snake bite. It is inevitable. Because in the field, the very poor people are working in the fields. It's very difficult to prevent that aspect. But only the patients will come with the snake bite. But other things, mostly poison by the attitude, by the public, that self-harm attitude. So that how we are going to prevent that, the self-harm attitude, like tablet or aluminum phosphide or organophosphorus, paraquat or ARD, whatever it is, it's mostly of self-harm compared to a snake bite. So how we are going to create awareness among the public to prevent this? This is a stress nowadays, especially in the 2020 and 2021. It's almost like a stress-induced new normal. We are living in a new normal due to COVID pandemic.
Yes,
To reduce the stress, how we are going to do this for this sake, toxicology aspect. And I really are doing good jobs, sir. Actually, I bow to you. Actually, this aspect, not only for the public, for the students, healthcare workers, even the healthcare service providers are affected due to the stress, heavy workload on this is a different workload actually. So your ideas for that, your suggestions for that.
Yes, madam. Regarding suggestion, only that is, we have to go to the community level, madam.
Yes, sir.
And we have to do to the community level, and we should form an organization. Then
Yes,
we have to sort out some protocols. Then we have to do, madam. But what you say is, mine is mostly clinical. Although I got a college of nursing also, and in the community people, I asked them to go and say, but this should be separately. We should form a department, and we have to do. But I don't think with my strain of this work, I cannot do preventive job, madam.
No, sir. No, I'm sorry to interrupt. Actually, I'm not asking you to do. So your suggestions how to improve, because everybody as a healthcare service providers, it is our job to involve all the categories of people, all the cadres of the healthcare service providers for this to prevent this stress as such, to prevent this self-harm. First point. Second point is except the snake bite or some insect bite, whatever it is. That's why I asked for your suggestions. Then regarding the stress, almost all the our medical college hospital, they have psychiatric department, psychologist, everybody is contributing their effort. And even during our clinical, even I am also an anesthesiologist. As an anesthesiologist, I say we are most oriented to the clinical aspect, but now we have to concentrate a little more for the mental aspect also. So like
Yes.
caring of the patient, not only the patient relatives during the intensive care treatment of the patient, all these things. That ideas can be shared. For that only I asked. Thank you very much, sir.
Okay.
I have a suggestion, madam, that if
Yes,
some
sir.
a good poster can be made for a minimal requirement, which can be pasted in all the wellness centers and PHCs of the state, it will be a
Yes,
good
sir.
IEC material. If you
Yes, sir.
seniors can sit together and formulate some a single poster which can be pasted in all the PHCs, it will do human wonders.
So yes, we are doing not only the posters. Already we are taking classes in batches for staffs and postgraduates and CRRIs, like that. For psychological aspects also we are covering, like during orientation. Like in our emergency department, we are managing all SAS a lot of toxicology patients also managed here, and whatever available with available resources, and with available resources like HR and equipment and consumables, we are trying our best. But still a long way to go. We have to improve. And as a university, VC madam has to support a lot of for research studies also. I request VC madam for that also. Thank you very much, sir.
Thank you very much, madam. Can I now request Dr. Raghunandan for his comments, sir? Please, sir.
Eppadi?
Thank you, sir, for your excellent presentation. And actually, before I make my comment, I request sir to touch on two important, I think, for want of time, you would have missed it. One is Chani powder, because Chani powder, Erode is authority and Coimbatore. So I was eagerly waiting that you will touch, because that's a very unique poison being taken only in the people in and around that district. So I would like to hear from that a few minutes. I know maybe you can even talk without slides also.
No, I can easily talk because
Sorry, sir. One more thing, that crane powder also something they used to say.
Gokumarande.
That also, sir. Thank you.
sir, it is, as you said, it is an extensive topic. When I saw it was only 20 minutes, then I asked VC madam. She said, you are the only speaker. You also requested her, because I revised this for 4 or 5 times. It was actually some 280 slides for these 4 topics. Excellent topic. Everything is a separate topic which we used to present. So that is a main lag. Anyway, I will tell this Sani powder, they produce severe electrolyte imbalance, sir. They produce severe electrolyte imbalance. They go in for hyperkalemia and acidosis. And once if you start correcting, and the Sani powder in the Erode area, it is good, but the Sani powder in the Coimbatore area and the Gobi-Chettipalayam area, they even dilute this copper sulfate. Copper sulfate also they dilute. So it has to be managed like that hematuria and all those things has to be managed. Last Sani powder end up on a ventricular. So for ventricular fibrillation and all, what we use is, we used to use this amiodarone and magnesium sulfate. I will send you the details because I don't remember the dose. But once if we correct the electrolyte imbalance early, we are able to save the patient, sir.
What will be the common clinical presentation, sir, when they take? Because I see that they may have seizures, one, and of course, hepatotoxicity also. That's what I heard from, because when we take classes for nurses from that area, they used to tell, suppose seizures, seizure, we know it has got high mortality, something like that they used to say. So what could be the clinical presentation, sir?
Sir, mostly in the initial stage, they don't get, but after 2 to 3 years, they do get. And these seizures are secondary to cerebral hypoxia due to irregular contraction of the heart. Once if we receive with seizures, once if we receive, we immediately connect them to the ventilator and we correct the ventricular arrhythmias, they become all right, sir. But if they come late, for example, we have got Satyamangalam, which is around 1.5 hours from Erode. They just walk and sit in the ambulance, and they are brought dead here. In the middle, they get 2 or 3 seizures. If we get them alive, we are able to save them. And because all in the periphery, they don't have this highly equipped lab services. To be frank, nowadays, this IL-6 and all, we have been using for snake bites for septicemia. After COVID, within 15 minutes, we get the value of IL-6, D-dimer, everything. Like that, we have got the lab facilities. It's an advantage. So immediately, the ABG, we are able to see they go in for severe acidosis and hyperkalemia, sir. If we correct them, they become all right. These things are secondary to gross electrolyte imbalance. And as you all know, suppose in poison, even all the people, physicians, if they receive a poison case, If they go in for fits and epilepsy, they go in directly, they go in for anti-epileptics, but even arrhythmia. But we have been taught if the patient has gone in for arrhythmias and fits in poisoning case, you first correct the electrolyte imbalance, the patient will become all right. So these are all the points, sir. So once you get, definitely they become all right.
Your experience on this emerging poisons like growth promoters today, we are seeing a lot of, apart from the, OPC and old things, carbamates, organochlorine, now people are indulging in this growth promoting substances which are not too toxic, I believe. So what is your experience in Europe, sir?
We don't get patients, sir. Can you tell me the name? We don't get growth promoters here now. Mostly we get aluminium phosphide and ratol. We don't get growth.
Okay, sir, I'll share our experience, sir. As far as ratol paste is concerned, it is really emerging, and we are seeing a lot of, in fact, last 1 week we saw 10 patients in 1
Yes,
week.
sir. I do that. I do that.
So that too, all are young girls between 16 to 20, and many of them, they may not know the seriousness of this poison. Just something like a paste, what you are, for that little amount, they just take it, and even they don't reveal to the parents or their friends or relatives. In fact, we used to get patients from medical gastroenterology OP because they would have taken some small quantity without telling, and slowly they develop jaundice. So once they get jaundice, they go to the medicine. Then from there they go to MGE. So when they take a proper history of the case, then they will indulge that they have taken some ratol paste. Then the patient comes late also sometimes. As you rightly said, it needs, especially when the ratol paste is highly fatal, and if the quantity is even little bit more than the normal thing what we are talking, it can be highly fatal. And you rightly pointed out about the supportive care, plasmapheresis and other things. But ultimately, the liver transplant would be the ideal choice in case the liver is very, very much damaged. That is one thing, sir. Similarly, regarding the other one is the regarding counseling, madam was also talking about primary prevention. Of course, primary prevention, we can have a helpline. Like in Chennai and all, we have a helpline called Sneha. So if somebody has got a suicidal tendencies, they can just call up this number and get some telephonic counseling. That services is available in Chennai. But one thing what we do in our hospital, in our poison center is we do counseling at the time of discharge so that they should not indulge in again poisoning. Suppose they attempted one attempt of suicide, they should not repeat it again later because the family situation, other things could be the same when they go back. So we do have a follow-up OP also. We ask them to at least come for follow-up for 1 or 2 months. So every Thursday we run a follow-up clinic for these people. And of course, we get the psychiatric opinion before they get discharged. And another thing is what we saw is another unique poison is the cart trap. That is also number of cases we are seeing little bit recently on the type, apart from our routine OPC poisoning. This chemical called cart trap is also being the thing. And of course, I want your opinion on use of plants. Those days we used to see a lot of oleander, all those things. Are you still seeing that, or it's gone now?
No, we see, sir. Even now we have got a case of oleander seed poisoning. We get oleander seed poisoning and Woodone poisoning. We get, which is very Woodone poisoning, which produces severe hypokalemia and acidosis. We get, but that is a bit rare now. But we get oleander seed poisoning in a crushed form. So symptomatically we treat, and they do well with the prophylactic transvenous pacemakers, sir. We are able to save them. Oleander seed poisoning.
Incidentally, maybe 2 years back, we had one interesting cases from Tiruvannamalai. It was well reported in the press and also because they were using this paste, ratol paste, for homicide. For homicide also, they tried to mix it slowly and give it to the family members like that. So we had a series of cases, unexplained death in Tiruvannamalai. Then we probed, and finally we found it was one fellow was using ratol paste as a homicide also. Anyway, it's a very, very nice to listen to you again, sir. Again, for the benefit of listeners, sir, I have been there to Sir's center a couple of times. He's doing an excellent work, and we should appreciate, even though he said it's a rural setup, he got all the gadgets and instruments and therapeutic interventions. And again, I wish him all the best, and he will continue to do good works. Thank you very much, sir.
Thank you, sir.
Thank you, sir. Wonderful, sir. Can I have Dr. Captain Raghavelu, sir? Opinion, please. Captain Raghavelu, please. Yes, sir. Dr. Raghavelu. I can see a hand popping there. Dr. Raghavelu, sir. In the meantime, is Dr. Ram Kumar available? Dr. Ram Kumar.
Ram Kumar, you can unmute and you can talk. You unmute and talk. Raghavelu sir, you can also unmute and talk.
Am I audible now, sir?
Yes, 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 you are
This is
audible.
Ram
Yes,
Kumar.
yes, Dr. Ram Kumar, please. Go ahead, sir.
Thank you, sir. Thank you for your excellent presentation. And your job is very commendable that you have taken the hospital care in the Erode district to a very greater extent, since we are doing ECMO and other treatment modalities also. And as a nephrologist, I would just like to give the basic points regarding what to choose, whether it is hemodialysis for a specific poison, or whether it is hemoperfusion, or whether it is plasmapheresis. The basic points based on which you can choose either of these modalities will be based on the molecular weight of the poison or the drug that the patient has consumed, and what is the degree of the protein binding of the drug, and what is the volume of distribution of the drug or the poison. And the fourth point would be based on the endogenous clearance of the drug or the poison, which means whether the kidney and the liver is active in the patient or not. If patient has got renal failure or hepatic failure, the metabolization of the poison or the drug may get delayed. So the endogenous clearance of the drug or the poison will be delayed. Hence, the renal replacement therapy may be effective in these patients. Based on the molecular weight, hemodialysis will remove any drug or poison which is water soluble, which has got a very low molecular weight, say around less than 5,000 Daltons. In these patients, hemodialysis can be effective if it is water soluble and if the molecular weight is low. If the drug or the poison has got a very extensive protein binding, then probably we will have to consider either plasmapheresis or a hemoperfusion. Hemoperfusion, as Sir said, works based on the adsorbent technology. And plasmapheresis, as we all know, it removes the plasma as well as the proteins which are present in the plasma. And with regard to the volume of distribution, if the volume of distribution is very less, single session or 2 or 3 sessions of renal replacement therapy would be fine, because the volume of distribution, what we mean is where are the places the drug has gone and deposited in the body. If it is just remaining in the blood, 1 or 2 sessions of renal replacement therapy can effectively remove the drug or the poison. But if the drug is extensively deposited in various tissues, and once you remove the drug from the blood, and if there is going to be a redistribution of the poison or the drug from the tissues where it is deposited again back to the blood, then we need repeated sessions of renal replacement therapy, whether it is plasmapheresis or hemodialysis or hemoperfusion. So these are the basic points based on which we decide what to choose, whether it is hemodialysis or hemoperfusion or plasmapheresis. And again, we need to know what are the complications that can happen based on the type of renal replacement therapy, because the renal replacement therapy again does not go without any side effects. There can be some problems that are associated with renal replacement therapy, and we need to proceed with the management or we need to be carefully, or we need to be aware of what are the complications that can happen because of the renal replacement therapy also. That is it, sir.
Thank you, Dr.
Can I
Ram.
talk, sir? Can I talk now?
Yes,
Hello?
sir.
Yes, sir.
Yes,
Sir,
sir.
yes.
Yeah, I'm very happy. Dr. Ganapathy has done an extensive work, and but that too particularly in the rural setup. I admire his work because in Stanley, it's a well-known center for toxicology in those days, even now. And as he said, we have not seen snake bite in Stanley. No, before I am gifted with that. I had a case in Stanley, that is after the Ganapathy left and before Shanti Miller came in that period. So that was one incident, but we successfully weaned off the patient and sent back to IMCU to Dr. Rajinikanth. So that is a different thing. I appreciate Dr. Ganapathy starting from that olden days and keeping pace with the modern development. See, that is the most important thing. He is keeping pace with the knowledge and the newer, acquiring newer technology to support his treatment. So that is a very good treatment plan, because you name the latest equipment available in the city of Madras. It is available in Erode in his center before that. See, that is the attitude, is passion towards treatment, towards the profession, towards the medicine. See, that is the one which keeps. And I appreciate if this sort of centers come around, at least one in one. Tamil Nadu is divided into 4 zones, at least one in one zone. Second thing is creating an awareness about this. What are the ways? We can, as we do the BLS work in work in schools and colleges and various places, we can also organize lecture programs by using healthcare professionals in schools, colleges, and workplaces, so that the better awareness is created. We can also make a film and show it in the theaters also. Sometimes the awareness will be better, because as Raghunandan said, in those days, I used to see cases of copper sulfate poisoning just for annas. 25 paise worth of copper sulfate they use and consume. And very good muscular young boys used to die in front of our eyes because of the bleeding and hypoxia, because of extensive pulmonary edema. So like that is a 4 annas worth causing so much of damage. So the awareness created is a much more important, particularly in the schools and colleges and workplaces. So that is one aspect. And one thing to be appreciated, Ganapathy as a student, as a MD postgraduate student, he used to go and discuss and convince the cardiologist in Stanley Hospital about certain things. He is maintaining the same thing even now. He is way of delivery. So it is so crystal clear for the others to understand easily. There is no bombarding languages, bombarding equations, bombarding dialogues, which makes the recipient more uncomfortable. These words of this thing is very, very simple, easily understandable. That is a very good gift Dr. Ganapathy has got. And there is nothing more to add, because he has covered almost all the latest treatment modalities for the poisoning. But he has not covered the entire gamut of poisoning because of the limitation of time. And I think given more time, we could have had. Thank you very much, Madam Sudha Sheshayan, and all the panelists for a very good, interesting evening today. Thank you very much.
Thank you very much, sir. Thank you very much for your insight. Would anybody else like to add anything on what has happened now, sir?
Ganapathy sir, thank you very much for your extraordinary contribution towards societal needs. And as Dr. Raghaveli said, the spirit in your still it exists. I pray
It's not
for
audible.
that. Then, sir, am I audible?
A little louder.
Yeah, you're
madam.
audible, ma'am.
You are audible, a little louder.
Yeah, thank you. Thank you very much, sir, Ganapathy sir, for your extraordinary contribution towards the societal health needs. Second is, most of the thing is, because of this, your compassion towards the job, your service-oriented profession towards the patient and their relatives, the right attitude, right needs, for the right needs of the patients. You are doing wonderful job, sir. Thank you very much for this opportunity given to me also. Raghu, and thank you very much. And VC ma'am, thank you.
Very much,
Sir.
madam. I shall convey. Dr. Raghunathan sir wanted to say something. Please, sir.
Sir, regarding the paraquat, I think we have to convince the government to ban or some regulated supply, because even as you rightly said, even 10 to 20, more than 20 ml is almost fatal
Yes.
now. So many of them, they do not know that by taking that, they think it is only to threaten the family or something like that. And later, after a few days, they really want to live and they die in front of eyes. So if you can pull the data of paraquat, and we have to do something together to convince concerned authorities, even to have some regulated, or if possible to ban the paraquat. Thank you, sir.
Even
Thank
aluminum phosphide across the counter they are getting.
But actually, aluminum
Almost.
phosphide, is it very common, sir, in Europe and other side? Because in
Yes,
Chennai,
yes.
we don't see that much. Chennai, I'm talking not only in Chennai, neighboring districts like Tiruvallur, Kanjivaram, we don't see aluminum phosphide. But I do see a lot of from northern states. For them, rodenticide, it's mostly aluminum
Especially
phosphide.
Chandigarh and all, it's very
Yeah.
common.
Yeah, that's what. But is it common in your neighboring
Usually,
districts, sir?
தென்னமரத்துக்கு வைப்பாங்க சார், எலிக்கு தென்னமரத்துல கீழே வைப்பாங்க நார்மலி.
குருண மருந்து சொல்றீங்க. குருண மருந்துன்னு சொல்லுவாங்க.
குருண மருந்து is humate, that is folate.
ஆமா, இது வேற. தமிழ்ல என்ன சொல்லுவாங்க சார் அலுமினியம் பாஸ்பேட்டுக்கு?
பெருக்கா மருந்து rodenticide. பெருக்கான் rodenticide.
Okay. Thank you, sir, once again for your excellent talk, and we hope to listen to you again and again. Thank you.
Thank you all for sir. Thank you.
Yes, sir. From what I have been hearing amongst the 4 experts in this room itself, we need to educate the public a little more on these common terminologies, sir. ஏதாவது ஒரு opportunity whenever it presents, if the list of all the material which should not be used or which are dangerous can just be put in one single place for everybody to see, it may do a great service in the prevention part that all of you have been talking about. Would anybody else like to add anything today, sir? Otherwise, we have had an extraordinary lecture from Dr. Ganapathy today. Thank you very much.
Next week itself, we have the next.
We have the next webinar in the next week itself. Dr. V. Mohan will be the speaker on 13/8, sir. Dr. Ganapathy, sir, has been an outstanding participant from the inception of the webinar, sir.
Thank you, sir.
And it's been a pleasure having you here today, along with your full set of critical care team here. And I hope all the members who have listened here will be the ambassadors to whatever you have told. Thank you very much for joining with us today, sir. Thank you again, all of you.
Thank you, ma'am. Thank you.